Good evening, everyone, or late afternoon for those of you on the West Coast. It's great to be with everybody tonight. The title of our webinar is called The ABCs of Adhesive Bonding and Cementation. And the topics of discussion for tonight are going to be discuss the different types of etching modes when adhesively bonding, discuss the different classifications of adhesives. We're going to talk about conventional cementation versus adhesive resin cementation. We'll discuss the different types of cements that are available today, and we'll also show some clinical cases to demonstrate the use of these cements as well as the adhesive modes. So getting into the program, we'll start off with a real quick disclaimer here. I am a member of Catapult, and I evaluate products in my office, and because of that, we talk about a lot of different products. A lot of these I've actually evaluated and I work with in my practice. I have no conflicts of interest, though. So we'll start off talking about bonding. You know, the interesting thing about this is that, you know, dentistry has changed so much that we live in an age and a time now where it's become so much more, you know, or I guess I should say less difficult to have a material stay on the tooth because we can actually bond a tooth structure. We didn't have that years ago, where we had to have everything had to be retentive, all our preparations had to be retentive. It required more tooth reduction in a lot of cases for our restorations. Today, we can be very minimally invasive because we can bond a tooth structure. And understanding this and understanding the etching modes and understanding the adhesives is very important when we're going to be doing the types of dentistry that are so commonplace today. So the first etching mode we talk about is the total etch. Some people refer to this as the etch and rinse, where we use phosphoric acid gel. We place it on the tooth. We say total etch. That means you're etching the entire surface of the tooth or whatever the surface is you're bonding to, whether it be enamel or dentin or both. When we use self-etch, that's a technique that was developed where we're etching mostly to dentin. It's very effective when you're etching dentin, this technique, because you don't use phosphoric acid. We're actually using acidic primers that etches and prime. They etch and prime at the same time. And then the third set is the selective etch is kind of a hybrid technique. It was developed specifically because self-etching primers work really well, as I said, on dentin. We can get high bond strengths to dentin with self-etching primers, but we don't get as good at bond strengths to enamel as we do with phosphoric acid gel etching. So for that reason, people started kind of intuitively saying, well, why don't I just etch the enamel and don't put any etch on the dentin, and then we'll use self-etching primers and we'll get better bonds to both enamel and dentin. And that's where the selective etch technique came about. It's kind of like a hybrid technique where you put the etch on the enamel but not on the dentin. So the advantages and disadvantages, let's talk about that, because it helps us, I think, to understand you know, these different techniques when we discuss their advantages and disadvantages. So the advantages of total etch are, as I said, about getting higher bond strengths to enamel. This is pretty much has been demonstrated through a lot of studies that we'll get higher bond strengths to both cut and uncut enamel with acid etching. We're going to get better bond to sclerotic dentin, and we'll have less risk of micro leakage, especially at cervical margins. So by getting these higher bond strengths or at cavo-surface margins. That's why we use this selective etch technique, let's say on a cavity preparation. By etching the enamel at the cavo-surface margin, you're less likely to get micro leakage there because of the bond to the enamel layer there. The disadvantage of total etch is that this is the reason I think that it's, you know, a lot of people don't like total etch technique because strict protocols must be followed. It leads to things like post-op sensitivity. You must isolate with a dry field. You have to follow certain steps, like dentin is anytime you etch dentin in a total etch technique, you're going to open dental tubules. And it's very important that when you're drying that you leave these dental tubules slightly moist, that you don't over dry them. And open tubules are more likely to lead to post-op sensitivity. So therefore, there's certain strict protocols that must be followed when we're using a total etch technique. The advantages of self-etch are they're simple and easy to use. It doesn't require etching with phosphoric acid. The etching is actually done with acidic primers. So you're basically, as you apply your primer to the dentin, you're actually etching and priming at the same time. Unlike acid etch, which removes the smear layer and removes and opens dental tubules, your base with acidic primers in the self-etch technique, you're actually permeating the smear layer. So you can get good bond to dentin, but you're not opening dentinal tubules. So you're less likely to get post-op sensitivity. The depth of etch is self-limiting so unlike acid etching, if you etch too long on dentin, you can etch deeper into the dentin than your adhesive can actually penetrate. But when you're etching and priming at the same time with adhesive primers, it's self-limiting. You can't etch deeper than you're priming. And it's not as critical to isolate with a dry field. In fact, if I'm using total self-etch technique, I rarely will isolate with a rubber dam but I'm much more likely to use a selective etch or total etch technique if I'm ever bonding to enamel. And I will isolate with a rubber dam in those cases. And you're much likely less to be post-op sensitivity if you're not opening dentinal tubules. The disadvantages are bond strength to enamel and sclerotic dentin are typically lower, and bond to self-cure, dual cure composites and cements may be non-compatible without the use of dual cure activators. So this is something you have to be aware of if you're using a self-etch technique and you're using a dual cure or self-cure resins and composites. So you have to read the manufacturing instructions. You have to know what the product capabilities are, but it's important to know. And a lot of that is because of the acidity of the primers, and it sometimes leads to incompatibility. So you just have to be really careful and know that you have to read the product's manufacturer's instructions. In the long-term bonded dentin may be susceptible to hydrolysis. We see this some sixth generation, which we'll get into in a minute, is not as critical because you come back over that with a separate adhesive layer, which will help keep this from happening. But when we get into seventh generation, which we'll talk about, they're much more susceptible to hydrolysis, and I'll mention that, and we'll go over why that is in a little bit. So, advantages of selective etch technique. So you're going to high bond strengths to enamel, and you're going to get high bond strengths to dentin and sclerotic dentin. So, and you can get this without having to acid etch the dentin. So this is what to me I think makes this a great technique, because you're going to get the best of both worlds. You get bond to acid, you'll get bond to enamel with the etch, and you'll get bond to dentin with the self-etch technique. And you're going to see less technique sensitivity because acid etch is not actually getting on the dentin. It's just on the enamel. You're going to have less risk of post-op sensitivity as a result of that. The disadvantages of selective etch, there is one big disadvantage of selective etch. Now, this is if you're using a 6th or 7th generation self-etch adhesive, that it's very important that the etch doesn't get on the dentin. So if it does, it can actually decrease bond strength. So it works well, and that's why your selective etch technique, you have to be very careful if you're using a 6th generation adhesive system, that you keep the etch just on the enamel and not let it bleed over onto the dentin, because you can literally be counterproductive and decrease bond strengths to dentin. So our etching mode. So if we're bonding, let's talk about when we bond to what surface and what we would use. So if we're bonding mostly to all enamel or mostly all enamel, traditionally we would think we'll use the total etch technique because we're going to get the highest bond strengths to enamel with a total etch phosphoric acid technique. Some enamel and some dentin, this is where we want that hybrid technique where we're going to bond. We're going to put acid etch on the enamel, and we're going to use self-etching on the dentin. So that's a great situation where you want to use selective etch technique. If we're bonded to all or mostly all dentin and there's little or no enamel that we're bonding to, then it makes no sense to me that we would just use a self-etch technique, because we're going to get high bond strengths to that dentin without needing to put any acid etch on the tooth, and it doesn't open up tubules. It doesn't increase the risk of post-op sensitivity or make it a more clinically challenging situation as far as isolation and dry fields and whatnot. So to me, these are all different clinical situations we encounter almost on a daily basis. And what I'm leading up to is that you want to use all three of these techniques. So it would be nice if you have a system that allows you to do that, which we'll talk about in just a minute. So our classification of bonding agents, we have the total etch 3 steps. This is what we call the 4th generation. The first step was you put the phosphoric acid on the tooth, the second, and rinse it off. Then you apply a primer and you evaporate the solvent and you apply your adhesive layer. The total etch 2 steps would be where you etch and rinse, and then you put your adhesive, your primer and your adhesive are in one bottle, and it's in a single step. So you're doing one step is etch and rinse. The second step is your priming and bonding in the same step. So it's basically what 5th generation did. It just took the 2nd and 3rd steps of the 4th generation and combined them into one bottle, just to simplify things. So the self-etch and selective etch 2 steps would be what we call the 6th generation. And that's where you can use a self-etch or selective etch technique, depending on if there's some enamel present. And the first step is you put your first step, if you're using selective etch, would put etch on the enamel margin only. And then you use your self-etching primers on the dentin. Evaporate the solvent and then come back with a second bottle, which is usually your adhesive layer. Up until about 10 or 11 years ago, before the introduction of universal adhesives, the only single bottle we had was a self-etching system. It called the 7th generation. And you could use this for self-etching also with a selective etch technique. And basically, like the 5th generation, which combined the primer and the adhesive into one bottle, I'm sure manufacturers were thinking it worked. And the 5th generation, by the way, worked really well. I used these for years and had very good success with 5th generations when bonding to enamel or bonding to enamel and dentin on fairly non-retentive preps like a porcelain veneer. The 7th generation, I think, attempted to do the same thing, where they would take the adhesive primer and combine it with the second bottle adhesive layer. The acidic primer, and combine it with the second bottle, the adhesive layer, into one bottle. And the problem was with 7th generation is I think they were just a little ahead of the time. The idea was a good one. It's just the chemistries hadn't been quite developed yet. And so the 7th generation became very, very susceptible to failure, especially to hydrolysis and to bond degradation over time. And they were pretty much incompatible with all self-cure and dual cure resins and cements. So, my recommendation for anybody I speak to today is if for any reason you are using a 7th generation single bottle self-etching only, you just have much better choices today. Much better choices. And this is supported by the literature. It's supported by people like Franklin Tay, John Powers, people like this, people that are the giants in this field that have done a lot of studies and would support this, the chemistries of the new universal adhesives just being so much better. And then you have the total etch, selective etch, or self-etch. And this is what we call the newest generation, called the 8th generation, or the universal adhesives. And they also are a one-step single bottle. But here's the interesting thing about universal adhesives. It doesn't matter which of those etching modes you're using, whether it's total etch, selective etch, or self-etch, you can use these adhesives with any of those. So basically, if you will, it could eliminate 4th, 5th, 6th, and 7th generations, because they're all unnecessary, because everything you could do with any of those generations, you can now do with a universal adhesive. So it really has kind of simplified the game. It's simplified product inventory, where you don't have to keep, because there are times where you might want a total etch technique if you're putting a porcelain veneer on. But if you're bonding, say, a crown on a molar tooth that has a non-retentive prep, you're going to probably want to use a self-etch technique. So to me, it just makes sense to have something that's available to us today that is good, because the chemistries have been improved. One of the big breakthroughs in the 8th generation universal adhesives was the acidic phosphate monomer called 10-MDP. And the incorporation of this into the adhesives is what really, I think, separated this generation from the others, especially from the 6th and 7th generations. The 6th generations, by the way, I should say, you can still have clinical success, and for years, dentists have had clinical success with 6th generation 2-step self-etchers, as long as you use a selective etch technique on the enamel margin. But again, you're making it a little bit more difficult on yourself, as opposed to just using the same thing and using a universal adhesive. They work just as well. So it looks like this. We have the 4th generation, you etch, you prime, and you adhesive layer. Then you have the 5th generation total etch. what you etch, and then you rinse and dry, and then you put your primer and adhesive on from a single bottle. In the 6th generation, you etch and prime in step 1, and then you evaporate the solvent and you come back with your adhesive layer. Then the 7th generation, as I just spoke about, was a single bottle, etch, prime, and adhesive all in one layer. And then 6th generation was improved by developing the hybrid technique called selective etch. I think that made the 6th generation really still a viable alternative today. But then the 7th generation, I feel like, should have been replaced by now by the universal adhesives, because we can do everything the 4th, 5th, and 6th generations can do with a single bottle. And it just makes life a lot easier for you. And if you're using one, you probably know this already. If you're not using a universal adhesive, there are a lot of them on the market, and it's probably worth looking into. So bonding agents, totals, just to go through some products, just to mention some products. So we talk about a generation, you go, well, is this a 4th? Is this a 5th? Is this 6th? So if there's any kind of, obviously there's many products in every category, but I'll just mention a few to kind of separate them out. So step 1, as I mentioned earlier, we rinse we put our phosphoric acid on and we rinse. We apply a hydrophilic primer and evaporate the solvent. Step 3 is we apply our hydrophobic adhesive, air thin and light cure. Total etch 3 steps. Some of these products would be OptiBond FL, Allbond 3, Scotch Bond Multipurpose Plus. These are just some of the products that you would see in this category that will still work today. It's just extra steps. And the other thing about this 3rd step, or the adhesive layer, are sometimes a little bit thick. So you have to be careful. And if you're wanting to cure that before you seed an indirect restoration, because sometimes they're a little bit thick, and you might want to use a dual cure activator so it will cure under restoration without having to light cure first. That's just to me, it's just one of the drawbacks of this. But other than that, 4th generations are still a very viable product. The total etch 2 steps of the 5th generations, I think, were some big improvements because it just made it easier and simpler. And etch with phosphoric acid and rinse. And 2nd step is they combine primer and adhesives into one bottle. You evaporate the solvent, you light cure. When you combine a primer with an adhesive, it kind of thins it out. So your adhesive layer is not nearly as thick. When you evaporate the solvent, all that's left is your adhesive layer, and it's very thin, and it won't interfere. You can light cure this with ease of, with comfort, not worrying about interfering with a seed of an indirect restoration. So for that reason, I think they work really well. And to me, I like this. I just, for years, but you really can't do with a total etch technique, you really can't do much self-etching or selective etching with as much as you can with a universal adhesive, but they worked well. And some of the ones I liked, Bisco's 1 Step, Prime Bond NT I've used with really good results, OptiBond Solo Plus, Excite F, with F is for the fluoride. Some of them these had contained fluoride, and then the single bond. So these are just some examples of 5th generation. So 6th generation, 2 steps, as we said earlier, you apply your acidic primer, you rinse, you dry the tooth, you apply your acidic primer. You don't have to isolate with a rubber dam when you're using self-etching adhesives. You can if you want, but it's just not necessary because you're not opening up dental tubules, you're not removing the smear layer. You put multiple coats of your primer, scrubbing as you do. Very important to understand. A lot of manufacturers will stress this, but a lot, if you're like me, a lot of times you don't always read the instructions real well. So it's important to know when you're going to do any self-etching technique and you apply these primers, you just can't paint it on and then evaporate the solvent. You got to actually take a little brush. You actually want to scrub the dentin. So the acidity of these primers can actually permeate that smear layer. Then you evaporate the solvent. Then in the 6th generation, we'll come back and we'll apply our adhesive, air thin, and light cure. So the reason is, so now we've got that adhesive layer that helps us when bonding and increases bond strengths and less likely to have, bond degradation over time. So they will work. OptiBond XTR, I mentioned this, it's got expanded functions. It's 6th generation because it's a 2-bottle system, but it's marketed as a universal adhesive because it does everything universal adhesives do, as long as you've got a 2-bottle system. Allbond, Bisco's Allbond SE self-etchers, Prelude, Danville's product adhesive, Mivaclar, and again, Clearfill SE Bond. And with their Protect for antimicrobial and anti-sensitivity. Cure was really the leader in self-etching. They were really one of the first people, and interestingly enough, Cure is the company that had pretty much discovered the 10-MDP monomer and had a patent on it for years. And when the patent ran out, this monomer became available to all manufacturers, and that's what I think has led us to where we are in the universal adhesives today. And then the self-etch one steps, I'm going to go through this, but it's just a single step. You apply your primer and adhesives all in one bottle, evaporate the solvent like Cure, and apply your restoration, and then place your restoration. Kulzer's Ibon was the first in this category, and then you had some others that came out, because you've got to remember at the time universal adhesives hadn't been developed yet, and because the 5th generation became so successful when they combined the products from the 4th generation, it was natural, I think, for manufacturers to think, well, we can simplify self-etching too by just putting everything in one bottle. The problem is it just didn't work as well, and there were fairly high failure rates with this generation. So I really kind of would encourage anybody to really, if you are using a 7th generation, please look into it, because there's better products, I think, available today, and I think most of the literature will support that. So that brings us to universal adhesives. It combines etching, priming, and bonding in one bottle. It's a single bottle. It can be used with total etch, self-etch, and selective etch techniques, which makes it good. So here we have a self-etch technique, here we have a selective etch technique, and here we have a total etch technique. This is what I'm talking about, an example of a class 2 restoration with a KO surface margin. I wouldn't, obviously self-etch works great on most of the preparation except that KO surface margin. So in the middle slide, you see this is a selective etch technique where the enamel is being etched at the KO surface margin for higher bond strengths there. I don't think it's necessary. I don't think it's wrong with rubber dam isolation you see here to do a total etch technique. I just think it's a little overkill. You don't really need it, because you're going to get high bond to the dentinal floor with using a selective etch technique. But you can use any of these 3 techniques with universal adhesives. They can be used for direct and indirect restorations. They have a very low film thickness of less than 10 microns. So when you light cure them, they won't interfere with the seat of a restoration. One thing that's critical to understand about universal adhesives, if you don't light cure it first, then you will get failures, okay? They go on hydrophilic, which is what we want, especially when bonding to dentin. So you want them to go on the adhesive to be hydrophilic, water loving when it's bonding to dentin. But to bond to resin, you want it to be hydrophobic. So a universal adhesive goes on hydrophilic, and once it's cured, it becomes hydrophobic. So, water repelling, but it's high bond strengths to resins. So that's why it's so important that you light cure your universal adhesive before you place a layer. Some companies now have materials that I don't want it, the scope of this doesn't allow us to get too complicated here, but there are some adhesive layers that will co-cure. In other words, they have chemistries in there that you place your layer and you don't have to light cure, because it cures with the material that you place. If that's the case and your manufacturer is saying it's not necessary to light cure, then you're fine, as long as it's curing with the material that you place, either the resin or the cement. But you have to understand that that's what the manufacturer specifies in those cases. But most of the time with universal adhesives, when you're placing a direct or indirect restoration, you want to light cure before placing that restoration. They're compatible with light cure, dual cure, and self-cure composites, unlike some other adhesives. Some require dual cure activators, some don't. Again, you have to read the manufacturer's instructions. It's very important whether you need to have a dual cure activator when bonding to self-cures and dual cures. So this is just some examples here. You can see the first universal adhesive on the market was Scotch Bond Universal, probably about 11 years ago or so. I think it was around 2011 when they were introduced. All Bond Universal by Bisco was very close after that, just a couple of months later. At the time I started using them, these were the only 2 available. I liked All Bond Universal simply because I'd been working with All Bond products and Bisco products for years in my adhesives, but also I didn't need a dual cure activator with All Bond, and I did with Scotch Bond. So that was a big determining factor for me. And I liked other things about All Bond Universal that they did with this, like decreased water content, which helps with long-term hydrolysis and bond breakdown. And the other thing is they had a slightly higher pH. which allowed you to be more compatible with resins and cements. So those are just a couple things, but the manufacturers have come out with great chemistries in these products, and all of them, you can see how many there are. You can go right down the list, and they're all good products. Just whichever one you choose to use, I would recommend that you read the manufacturer's instructions. I think it's really important, whether you need a dual cure or not, or how many layers you put on, how long do you evaporate the solvent for, how long do you light cure that layer for? All these things, it's important to understand and to know. So an ideal bonding agent, we want ease of use, which it doesn't get easier than one bottle. Fewer steps doesn't get easier than one bottle. We want it versatile, doesn't get easier than to be able to use it with every etching mode. Okay, whether it's self-etch, total etch, or selective etch, would be compatible with all self-cure, dual cure, and light cure resins and cements. We would want it to be that, and universal adhesives are. We want high bond strengths to cut and uncut enamel, and to dent and sclerotic dent, and we have that as well, depending on which etching mode you use. We want a low film thickness, which we have with universal adhesives, which won't interfere with the seed of restoration. No post-op sensitivity, and I can say this, absolutely from my own personal experience. I have been using universal adhesives for almost 10 years, or at least 10 years, and I have no post-op sensitivity. So it's just not a problem. In fact, I don't even think about it. So when proper protocols are followed, it is not something that I think needs to be a problem anymore in today's dentistry. No micro leakage. We would expect that again, no micro leakage with proper protocols. So that brings us to cementation. So let's talk a little bit about cements and about the cementation process. So I consider cements all, basically in two categories. What I call conventional cements and adhesive resin cements. Conventional cementation to me simply means you don't do anything to the tooth other than rinse and dry, or maybe put an antimicrobial on there, something like that. That's all. You put no adhesives on your tooth, and you do nothing to the restoration other than rinse and dry it. You don't put any primers or anything on the restoration. So you're not treating the tooth, you're not treating the restoration. Adhesive resin cementation, on the other hand, does require you to treat both the tooth and the restoration. And there's certain ways that you go about doing that. There's certain ways that you treat the tooth and how we bond to the tooth, and there's certain ways you treat the restoration, both cleaning it and priming it. And we'll go over that and we'll talk about that. But every cement in my mind falls into one of these two categories. In fact, you can actually have an adhesive resin cement and I consider it a conventional cement, because there's certain adhesive, what we call self-etch adhesive resin cements, where you don't have to treat the tooth or the restoration. So your self-adhesive cements fall in the category, even though it's a resin cement, of conventional cementation. And we'll talk about that. So do we cement or bond? Well, the question is, when I ask this in an audience, and I ask, would you rather cement or bond? Almost all hands go up for cement, and I don't blame them. My hand would be up too, because it's easier, it's simpler. I mean, when we can, we would rather cement. But there are times when we don't have a choice. We need to bond, and we need to understand how to bond, because with bond, it will increase bond strengths. And so therefore, there are times that cementing alone is not adequate, or won't get us a clinical result that we want. So we cement, it's less steps and it's easier. We don't have to treat the tooth or the restoration. It's easy to clean up. These new cements today, I'm telling you, it's just night and day difference from what it used to be. For young dentists, you just don't know how good you have it. You don't understand what some of us older dentists that have been around for a long time, what we've encountered over the years. You can't imagine taking impressions the way we used to have to do years ago, mixing up rubber base, squeezing something out of the tube that smelled terrible, mixing it together on a pad, and putting it in a syringe and squirting around too. I mean, and the same thing with cements. We had to mix zinc phosphate cement up on a glass slab so it wouldn't set up too fast. And we had to have the exact right amount of powder and the exact right amount of liquid, and you had to mix it in a wide area over a glass slab. I mean, this dentistry has gotten so much easier now. We do our impression materials out of a gun. We do our cements out of a gun. And if we're not even, and a lot of people, we're not even taking impressions anymore. We're just taking a machine and we're scanning an arch, or we're scanning a preparation. So everything has gotten so much easier than what it used to be. But nowadays, we also have another thing that I think we're going to hear more and more about. I believe we're on the cusp here of some real breakthroughs, and we're going to see this as time goes on, because technology is improving. and everything is going in a certain direction. One of those, I think, is what we're discovering is regenerative ability with ion release. And so there are some cements now that are incorporating ions like phosphate, fluoride, calcium, that these ion releases are beneficial to the tooth and beneficial to the longevity of the restoration. So we're going to be able to cement now and maybe increase restoration longevity by cements that we're using. And we bond because if we have a non-retentive prep, we bond for retention. We bond also, here's the interesting thing. If you ever wonder why a porcelain veneer, which is very thin and very fragile, and then it's bonded to the tooth and all of a sudden it becomes very strong and it doesn't break when it's bonded to enamel, it's because the bonding procedure, actually bonding to tooth, actually strengthens the material and it'll become very strong. And that's why porcelain veneers bonded to enamel will hold up for such a long period of time. So you can actually strengthen the material by adhesively bonding it. And the other thing is we bond for aesthetics. And a lot of times, a lot, I should say, of our non-retentive preps usually involve anterior aesthetics. So when and most of our cements, our conventional cements, are not usually very clear or not aesthetic cement. And if we're using one of those for a very thin restoration, color-wise, it might not give us the result we want. So adhesive resin cements allow us to bond for strengthening material, for extra retention, and for aesthetics. So conventional cementation, I mentioned zinc phosphate cements. I mean, do they work? Sure. If you got a retentive prep, any cement will work. If you have, say, 4 millimeters of axial wall height and you've got 6 to 8 degrees of taper, you could use almost any cement and your crown's going to stay on the teeth. I have patients that I've seen in my practice that have gold crowns or gold work that was done in their mouth 30, 40, 50 years ago, and those crowns are still in. And they were probably cemented, very retentive preps that were cemented with zinc phosphate cement. Now, are they as good as today's cements? No, because they don't offer the benefits. And if you don't have a really, really well-fitting margins. I mentioned gold crowns because we were able to get really, really well-fitting margins with gold. Unlike some of the materials that came later, where maybe the marginal integrity wasn't quite as good, and maybe these cements that have a tendency to wash out and allows for marginal breakdown. But suffice it to say, at one time, both zinc phosphate cements and zinc polycarboxylate cements were both, good products. I just don't think they have much use in dentistry today because there are better products available. I have colleagues and friends that like glass ionomer cements, still use them, still love them. Their ease of use, their moisture compatibility, their fluoride release, both for marginal protection and antimicrobials benefits. It's just, there are a lot of great things about glass ionomer cements. It's just that they have been, strengthened and improved by incorporating resin. So that's the new category of glass ionomers called resin modified glass ionomers, which gives you kind of the benefits of resin cements and the benefits of glass ionomer cements combined into one cement. And, these are some really good products. And these are some products that have been out for a while now. They originally were, you had to mix them. They came, with a powder liquid that you mixed. Now they're in the dual barrel syringes that makes them so simple and easy to incorporate right into your restoration. So, to extrude right into your restoration. So they're simple and easy to use. They do have fluoride release, and they are stronger, and they're more durable in the mouth. Then not a newer category, these have been out for a long time too, are the self-etching, self-adhesive resin cements. And these were developed, at least 20 years ago. And basically it's just a resin cement that gets, because of the chemistries, will get some bond to tooth structure. Not a lot, certainly not like treating the tooth and treating the restoration, but because of some bond to tooth and some bond to restoration, you'll get bond strengths of maybe 5 to 8 megapascals. So on a fairly retentive prep, these will work really well. And again, you have the benefit of the resin and the characteristics of a resin cement that make it stronger and make it less susceptible to fluid breakdown from saliva and things like that at the margins. So you're going to have some benefits for these type of cements, mainly because they're very strong cements and they're simple and easy to use, and you will get some bond to tooth. but not in a non-retentive preparation. You probably won't get the kind of bond strength you need to hold your restoration on, or make sure you're going to have a restoration that stays on. Then the last category I mentioned is the newest of the categories that have been out, and that's the what I call the ion releasing. Some people call them the bioactive cements. In fact, Activa pulp dense product, Activa, actually is the name of the cement, the Activa bioactive cement. It releases calcium fluoride and phosphate ions. Theracim and Ceramide Crown and Bridge release calcium and fluoride. Theracim is a great product by Bisco. I've been using this for a long time and I love it. It's simple and easy to use. It is a calcium fluoride releasing, and because of the calcium release, it allows an elevated pH. It's, so therefore you're going to get all the benefits to the kindness to the tooth structure, the antimicrobial benefit, all the things that you get with an elevated pH, an alkaline pH that we know in dentistry have become very beneficial. Theracim is also a member of the Bisco's Thera family. It started with their TheraCal, their pulp protector and pulp capping agent for both direct and indirect pulp cappings. And it's their most recent is the TheraBase. And all three of these release calcium ions, and all three are, I think, really great products that I happen to like a lot. But Theracim is simple, it's easy to use, it's easy to clean up, and there's some extra benefits I think from this category of cements. Just like when Universal Adhesives first came out, there was just a couple of them, and then there was 3, and then there's 4, and now there's a multitude of them. I think we're going to see this with this category of cement. I think you're going to see more and more manufacturers coming out, and they're already starting to, because the future is very exciting in relation to bioactivity and what actually all the benefits that we might see, especially in marginal breakdown, recurrent decay, things like this, and restoration longevity. So just some things to think about, but these are all listen, there's any of these categories, and I'll wrap it up at the end by telling you what cements I think are good, but I don't think you need a multitude of cements. I think you need one conventional cement, whichever category it is. I'll back up really quick. It could be, in my mind, you could use a resin modified glass ionomer, you could use a self-adhesive resin cement, or you could use a category of an ion releasing cement. But that's all. You don't need one of each category, okay? Because they all work well. And that's just too much product inventory. I think what you want to use is pick which category you like and what works well in your hands. And if you're happy with that, fine. But you also need adhesive resin cements too, because there are times we need to bond. And there's 2 categories of adhesive resin cements. There's the dual cure resin cements, and there's light cure resin cements. Okay, dual cure is when the material won't polymerize with a light alone. If it's a thicker restoration in the back of the mouth or something like that, you might need the cement to cure both with a light and without the light. Light cure resin cements are for anterior restorations that are thin and very translucent. The light can penetrate the restoration and polymerize the resin with, completely without needing chemistries to cure. So dual cure resin cements, Bisco's Dual Link I like a lot. G-Sim's Link for it's a relatively new product. And Kenbod just came out a couple of years ago with Salis Simcore. It's a great little product because it's a dual cure resin cement, and it's a core buildup material with dedicated primers that come with the materials. So it's kind of like 2 products in one, which is pretty interesting. You'll get your dual cure resin cement, but you'll also get a core buildup material. So interesting product, but all of these are really good products. Light Cures, Zest Accolade PV, it's very, very radio opaque. It's easy to see. They've got a nice clear shade. Pulp Dense Clear Veneer is a really clear shade. If you're looking for something with no color, you want a really clear shade, it's well named. And Bisco's Choice 2, I've been using that for years and like it a lot. Some companies have both light cure and dual cure in a kit, which is nice because there's times clinically where you need both light cure and dual cure. So it can come in pretty handy sometimes to have both. And Ivoclar has the Verilink, Acetic, the LC, and the DC, light cure and dual cure. Bisco has got the E-Cement kit, which has a light cure and a dual cure in it. And Kerr has the Nexus 3rd generation, the NX3, that has a single barrel and a dual barrel. So in this category, you either need one of these kits or you need a light cure and a dual cure. I think so. You only need one conventional cement, but you're going to need two adhesive resin cements because there'll be times when you need a light cure only, and there'll be times when you need a dual cure. And people say, well, there's new chemistries now in dual cures. They've eliminated a lot of the tertiary amines that led to discoloration over time. So without that, and we don't have to worry about it discoloring, why can't we just use a dual cure everywhere? And the answer to that is yes, except that your working time is severely limited. So if you're putting in multiple restorations, the great thing about a light cure resin cement is it gives you more working time, as opposed to a dual cure where you're really limited to just a couple of restorations at a time, because the self-cure mechanism will take over and that chemistry will start that curing that cement maybe before you're ready if you're putting in more than a couple of restorations. So that's why I think you need both and why I think you should use both. So what do we want in ideal cement? Easy to mix, low film thickness, low viscosity, adequate. This is all pretty straightforward and standard, and most of them have this. When we are asked to evaluate products, we're asked all of these things. How easy was it to mix? How is the film thickness? How is the viscosity? So we answer all those questions in our evaluations. Do you have adequate working time? Is it a short setting time? Because you want the working time, but you don't want it to take too long unless it's a resin cement and you're using a flash cure technique, which I'll talk about in just a minute. Is it insoluble in oil fluids? This is one of the advantages I think of the resin cements is that they're a little bit more insoluble in oil fluids. You want a high shear strength, tensile and compressive strength. You want to be able to bond to two structure, able to bond to restoration, biocompatible with pulp and soft tissue, various shades, and radiopacity. Radiopaque cements are very important, both for resins, composite resins, and cements, because nowadays, if we don't have that radiopacity, sometimes it's possible that you can see a layer in there and you might mistake it for decay if it's not very radiopaque. And that's why it's important. And we like various shades, especially when we're seeding resin cements for anterior aesthetic restorations. But any of those categories, with a few possible exceptions, like the conventional cements, you don't need a lot of shades with conventional cements. A couple of shades, all you need. But resin cements, you're going to need more shades. But most of these characteristics apply to all the categories we've discussed. An easy cleanup, that just goes without saying. I mean, the easy cleanup, you're going to see with almost all these, a lot of them will set to a gel state, makes it easy to clean off. In resin cements, what I like to do is what I call a flash cure, where I'll hold finger pressure or cotton roll pressure, and I'll take my curing light and at the margin, the excess cement, and I'll just cure it for a couple of seconds, and it sets it to a gel state. And then I clean off that and floss the contact, and then I bite on a cotton roll and let the cement self-cure for another couple of minutes before we finish, and then we'll come back and light cure after that. So that's how we do our dual cure resins. So let's look at let's wrap this up. I'm going to move along here because I got like 5 minutes, maybe just about 5 minutes left. So we're going to look at three different techniques. Okay, we're going to bond glass ceramics with a total etch technique and a light cure resin cement. Then we're going to look at a posterior using a glass ceramic with a self-etch technique and a dual cure resin. And then we'll talk about how do we bond zirconia. And we'll wrap that up talking about bonding zirconia, because there's a lot of confusion. There's a difference in how we bond glass and how we bond zirconia. And there's very strict protocols you need to follow when you're bonding zirconia. Now, if you've got a retentive prep, I don't bond zirconia, okay? I mean, I just clean it out, I rinse it out, I clean it with a zirconia cleaner, and then we put our cement in there, we put on the tooth, and we clean it off. So we just do a conventional cementation of all our retentive zirconia. But I do not, I can't say that you're never going to have a non-retentive situation for zirconia. You might have a second molar that's got a very low axial wall height or something, and it's just non-retentive, the crown comes off, you may want to bond it. We have wing bridges that we use zirconia wings. It's non-retentive, we need to bond that. So there are times you need to bond zirconia, so we're going to go through that really quick. So first step in cementation of glass, when you're using a total etch technique, you can't have any bleeding, so you've got to control that. I'm going to do this really quick because I'm going to show pictures of what we're talking about. So we isolate, we place phosphoric acid gel, we rinse it, we apply our solvent, we apply our agent, evaporate the solvent, light cure, place resin cement on the teeth, seed all restorations. We clean excess cement with gauze, cotton rolls, and brushes. I should mention here really quickly too, because I'm getting a little quick here at the end. My website is thomasdudney.com, and handouts are on my website. Anybody is welcome to go to my website, and all this information you're seeing, obviously you're not gonna have time to write all this down because we're going quick, but you can go to my website, thomasdudney.com, and get the handouts off the website. Tack restorations, gingival margins, floss, the contacts. So we're seeding multiple restorations. That's another reason why we're using a light cure cement here. And I want to floss the contacts, but I don't want the veneers to move. So we tack them at the gingival margins so they won't move. So this is what it looks. So after this is, now that's how we treat the teeth. Now, how do we treat the restorations? Well, porcelain, you can treat with anything. You can clean it with anything, including phosphoric acid. Or you can clean it with a cleaner like Ivoclean or Zerclean, okay? Then we rinse, we dry. Now, glass can be etched, so you're going to apply silane to it because you can etch glass with hydrofluoric acid. So it usually comes from the lab etched. We allow it to sit for 1 minute, we dry, we set it aside by tooth number in place. So here's our rubber dam. We're going to go ahead and we're going to place our rubber dam. It's simple, it's easy to do. You just put 2 clamps on the molar teeth and we fold the lip up underneath. This, if you see this, let me see if I can get the arrow on that right here. This line, you just cut, you make 2 holes, cut a line between the 2 holes, use wingless clamps on the molar. You fold this up underneath the lip and you take those 2 and roll them over the back of the clamps. And that's how we apply our rubber dam. Now we got, and you can put some gauze in the palate if you want. We're using our antimicrobial. We're etching 5 teeth at a time and rinse. This is Bisco's Select HV Etch. It's the HV stands for high viscosity. Select because it was developed for the selective etch technique because it stays right where you put it. And that's why I like it. It doesn't bleed over onto the gums. And it also has benzalkonium chloride in it, which is an antimicrobial. So it's got an antimicrobial incorporated right into the etch. And I like that feature a lot. So we rinse these teeth off. Now here we are, we're applying our universal adhesive. We apply this in multiple coats on all the teeth. And then I'm gonna go through this kind of quick. But what the thing to me is, I want to point out, I mentioned this about universal adhesives. If you put this on a piece of foil and you paint it with universal adhesive and drop water on there, it disperses because it's hydrophilic. Once you cure it with a light, it becomes hydrophobic, and you drop water on a cured All-Bond universal and you notice the water beads up. The importance of understanding that is that proves that this material becomes hydrophobic after it's light cured. And that's why it's so important for it to be light cured. Can't stress that enough. And you have high bond strengths, 35 megapascals of bond strength with a total etch technique on cut enamel, very high bond strengths. So we apply it, we evaporate the solvent, we light cure. We're going to put our choice 2, we're going to put it right onto the teeth. I feel like it's easier to seat porcelain veneers if you put the restorations right on the teeth. We put the cement on all the teeth and we seat all the restorations at one time. We can work hands-free because the rubber dam isolates everything. We're going to make sure everything's seated. Then we're going to wipe away all the excess cement, facial and lingual, with cotton rolls, gauze, and brushes. And then we're going to come back and tack at the gingival margin, just like I was saying, holding these in place. And once we tack them down, we can come back and floss. If you can't get floss through, take one of these little metal strips and go down and straight out. And then you can go ahead and floss all your contacts. Then we light cure. We remove any excess from the gingival margin with a scaler. We adjust the occlusion, polish interproximally, check the occlusion, and then polish. And then we're done. So glass ceramics posterior, same thing. You do everything the same, except this time and how we're doing it, we're going to treat the glass the same way because this is a posterior glass ceramic crown, like an Emax crown. And it's going to come back from the laboratory etched. So all we're going to do is clean it, dry it, and put silane in it. Okay, but the teeth we're going to be doing differently because we're using a self-etch technique now. So we don't need to treat the teeth and we don't need to isolate with a rubber dam. So we're going to put cotton rolls in there and we're going to use our universal adhesive in a self-etch technique. And we're going to paint multiple coats, scrubbing the dentin, and then we're going to evaporate the solvent. And then while I'm doing that and light curing the adhesive layer, my assistant is rinsing, cleaning the crown, and she takes the automix syringe and injects it right into the crown and hands them to me. I use finger pressure or a cotton roll. I flash cure for 1 to 2 seconds, remove the excess, and bite on a cotton roll for 2 to 4 minutes. So lithium silicate, if it's milled in your office, if you are milling in your office, you need to etch glass ceramics in your office. And you probably already know that. Hydrofluoric acid on Emax on lithium silicate should be about 20 seconds. Then you clean your surface and then you apply your silane, wait a minute, let it dry, place the resin in the crown. These are 2 Emax crowns. You can tell because they're frosty. They've been etched in the lab. So we're going to put our silane, our porcelain primer on there. We put that on the teeth. And while my assistant can do all of that, and I've isolated with a cotton roll here, I'm using self-etch. I'm putting no etch on these teeth, just my self-etching primers. I'm painting multiple coats on there, evaporate the solvent in light cure. While I'm doing that, the assistant puts the dual cure resin cement in the crown. I put them on, I hold finger pressure, light cure for 2 seconds, and then my scaler will just peel that right off. Excess comes off real fast and real easy. And just so they're not, and I floss the contacts. And then if it's a dual cure resin cement, I want to let the self-cure chemistry work for a little while. So we wait a few minutes, 2 or 3, 4 minutes, and then we come back and light cure that afterwards. And the last technique is zirconia. So we're going to bond zirconia. Now there's different ways. I mentioned the fact that we bond zirconia. Usually, only time I bond zirconia is in non-retentive situations. Zirconia is very difficult. It's the reason I don't do a lot of glass ceramics posterior anymore, unless it's non-retentive, because it's just too hard to take these crowns off if you ever had to. And I don't want to bond zirconia routinely, because if you ever have to take the crown off, it's just too hard when they're bonded on. But in a non-retentive situation, we do. But this is specifically how you treat zirconia. It has to be treated properly to get the highest of bond strengths. So the first thing we want to do is we want to decontaminate it. It's critical that you decontaminate zirconia. Unlike glass, you can clean with anything. You need to use cleaners to decontaminate. You want to air particle abrade. You want to use your primer, your zirconia primers, your metal primers, and you want to place your composite resin cement. Those are your steps. So our cleaner, what we decontaminate with, you can use Ivoclean. I like Visco's Zirclean. You do it for like 30 seconds. You decontaminate the intaglio surface. You rinse and you dry. Then you air particle abrade with aluminum oxide. We place our ceramic primer, Z Prime Plus. Now, the thing about these primers, zirconia gets contaminated because it has an affinity for phosphate. So there's phospholipids in saliva, which will contaminate zirconia when you try it in. That's why it's so important to treat it with zirconia cleaner. And then you can increase bond strengths. Studies have shown by air particle abrading with aluminum oxide. Then we're going to put our ceramic primer after we rinse and we dry. We put Z Prime Plus or Mono 1 Plus, something like this, as zirconia primer. And then we place our dual cure resin cement in the crown, and then we seat. Do the same thing. We'll put our flash cure, and then we'll remove the excess and floss the contacts. This is an example of zirconia wing bridge, and these are the wings are made out of zirconia, and the facial is layered with a more ceramic with a more aesthetic ceramic. But the wings are zirconia. That's what's bonding to the tooth. So we're going to treat these the way I just showed you, because this is a non-retentive situation. But we'll show you again. So here we have 2 crowns. Let's say, and you can tell because they're not frosty. So you can't etch these. They're acid resistant. They won't etch. So here we are cleaning it. After trying, we're decontaminating it. Then we air particle abrade it. Then we put our primer in there after air particle abrade. This is our Z Prime Plus. We're painting it in the crowns. We're putting our dual cure resin cement in the crowns. My assistant does this. My assistant does all of this. She decontaminates it. She air abrades it. Okay, she rinses it, she puts Z Prime Plus in, and she dries that, and then she takes the dual link or whatever dual cure resin cement you're using, she places that in the crown, hands me the crowns. While she's doing that, I've got isolated with the cotton rolls. I'm using my universal adhesive, just like we did with the Emax crowns, scrubbing the teeth, evaporate the solvent, light cure. She hands me the crowns, I seat them, I do the flash cure, and we remove the excess. We floss the contacts, and voila. So high bond strengths, you're going to get almost double the bond strengths if you use a zirconia primer as opposed to using a self-adhesive resin cement or something like that. So it's really beneficial. So I get asked, what cements do I use and when and what clinical situations? So we're talking about not adhesive resin cementing, but conventional cementing, either glass ceramics, zirconia, layered zirconia, or metal ceramics. And I have a retentive prep. You can use resin-modified glass ionomers, self-adhesive resin cements, or the bioactive ion-reducing cements. I think they all work. In a non-retentive situation, I'm going to bond with a universal adhesive and a dual cure cement. Okay, with that, I'm going to have to take it back to y'all, and we're going to do a quick Q&A here. All right, so I'm going to answer questions, and I'll check back in with my people, and if they're okay, if we have questions and we can run over about 5 minutes or something, I will. I apologize. I was trying to do it in 50 minutes, and I did 55. So we were going to allow 10 minutes for questions. So we've got at least 5. So I'm looking for the Q&A here. Okay, boom. I'm pulling up my screen. I'm looking to see if there's any questions at this time. I'm happy to entertain questions. I appreciate everybody's attendance tonight. Again, I know it's a pretty big topic to cover in a fairly short period of time. So I know we got a little bit fast there at the end. I apologize for that. Just to reiterate, if you didn't have time to write anything down, my website again, thomasdudney.com. Feel free to go there. All handouts are on my website for this lecture and other lectures, and you're welcome to that. Okay, so here we have a question. For single tooth replacement, a bridge, doesn't the newest literature recommend single tooth abutments? Yes. Okay, so that's a good question. I'm assuming that they're talking about the wing bridges. So yes, cantilevering wing bridges are something that we're doing more now. In my younger patients, the reason I use 2 wings is because a lot of times in young patients, they're not old enough for implants yet. In the case I showed you, this was a patient that may want to convert to an implant later on. And by doing 2 wings, it keeps the roots from drifting. And then they don't have to go back through ortho to straighten up the roots to have room for an implant. But otherwise, I'm getting to where I do a single wing off a canine now. So yes, that's a good question, and I would agree with doing single wings, cantilever the wing bridge off the canine with the lateral ponic. Other thing nice about that too is that not only is it less preparation, you don't have to do anything to central, but it's much easier to floss because you can floss through the mesial contact of between the mesial of the lateral, between the lateral and the central, and just go right underneath the ponic. So that makes it nice. Is air abrasion necessary after ivoclane? I thought the labs air abrade our crowns. Okay, yes, but the air abrasion, I think, it's a good question. Okay, some labs may air abrade zirconia and some may not. But yes, I think it's worth air abrading after you clean the tooth. I think it's just, what are you looking for? Is your crown going to fall if you don't air braid? Probably not. Okay. Are you looking to maximize the benefit of your bond? Because remember, the only reason we bond zirconia is because we're bonding because it's a non-retentive situation. So we want to maximize the bond, get the best we can possibly get out of it. So for that reason, I would tend to say, let's follow what the experts say. Let's follow what the manufacturers say. So even if it were air abraded in the lab, I would still say, I think it's a good step to do. And when I talk to the experts and I talk to the people that I respect, like Rolando at Bisco, we've had some conversations about this. We talked about Z Prime Plus years ago and the benefits of that, and they recommend doing air abrasion. So I'm not the expert here, believe me. I'm just sharing information of what I've learned from other people that I respect in the industry and who that know a lot more than me. So I hope that answers the question. For non-retentive preps with posterior zirconia crowns, if we don't have access to bonding materials, what cementation protocol would you recommend? Resin modified glass ionomer, self-adhesive resin cement? Well, I would get access. Okay. For non-retentive zirconia crowns, I want a universal adhesive and a dual cure resin cement. Now, if you have an adhesive, I don't think you're going to get as good a bond strengths with a self-adhesive resin cement, even if you use an adhesive layer. It's probably better than no adhesive layer, but I would still try to get a universal adhesive and a dual cure resin cement. Short of that, I would use a self-adhesive resin cement over resin modified glass ionomer, but that comes with conditions. I'm answering that with conditions. My preference would not to be to use either. Okay, it's a good question. It's a fair question. But for non-retentive posterior zirconia, I want the highest bond. Like I said a minute ago, I want to maximize bond. I don't want to compromise anything if possible. And that would mean using the best, and the best would be an adhesive layer and dual cure resin cement. Sodium hypochlorite 3% as an alternative to ivocline for decontamination. No. Okay, it may be, okay? Sodium hypochlorite might be, the thing is that basically what Ivocline and Zircline is that they're basically it's a slurry. It's a like a potassium slurry that actually removes the contamination from the surface. I don't know if so. I'm sorry, I'm going to have to plead the fifth. I can't answer this definitively. My understanding is that your best bet for cleaning zirconia is with a dedicated zirconia cleaner like Zircline or Ivocline. I can't answer because I don't know specifically sodium hypochlorite. You would have to ask that somewhere else. I'm sorry. Let me see if that's, oh wait, there's a couple. We'll try to get to a couple more, one more here. In dentistry, a general rule of thumb is to follow the manufacturer's instructions. How come 3M's Relax Unisim doesn't mention to do any of these extra steps? See, Unisim is a great product. Unisim was actually the first in that category, the first one out. And it was kind of like the leader in this category. So it's a good product. I don't use it, so I'm not familiar with its instructions. But the first part of that sentence, the general rule of thumb is to follow manufacturer's instructions. I couldn't agree with that more, okay? And that is a general rule of thumb. And that's something either with your rep or with 3M. Again, I apologize for not having a better answer for you there, but I'm not familiar with why it doesn't mention to do any of these steps. I don't know when it says mention to do any of these extra steps. I'm not really sure what you're referring to. Extra steps to me. Now, Unisim doesn't need any extra steps, okay? It doesn't. You don't need to treat. You can use 3M Relax Unisim on a retentive preparation without treating the tooth or the restoration. So there's really no extra steps necessary there. And that may be why it's not in the manufacturer's instructions. That's possible. I'm sorry, I know that's not the best answer, but that's the best one I could come up with. Let's see if there's, oh, yeah, here we go. I'm gonna answer a couple more. Trung, if I run over and you want to come in and cut me off, that's fine. But until you do, I'm just going to keep answering them as they come in. Thanks. Oh, okay. Somebody said they found my handouts. Well, great, Herman. Thank you for letting me know that. They went and found the handouts. So a lot of this information, again, that where they have long lists, they're in the handouts. So hopefully you didn't try to write it down. What do you think about hybrid etch in which you place etch on the cavo surface margin for 10 seconds, then place etch on the dentin and 10 seconds later and rinse that off? That way enamel gets 20. Yeah, there's a lot of schools of thought. I don't think you need to do that. 20 seconds on enamel, 10 seconds on dentin. When we first do total etch technique, they said, when you're doing a total etch technique, you're etching. With a self-etch technique, you don't need to do that because you don't need any etch on dentin. But if you're using total etch and you've got some enamel and some dentin, yes, it probably is better to etch the enamel first and then the dentin, because it's okay to have etch on enamel longer than it is the dentin. You prefer not to have etch on dentin longer than 10 to 15 seconds. That's really about and the reason for that is that you can etch deeper than you can prime. So with acid etching, so you don't want to etch too deep, because you might etch deeper than your priming, your adhesive layer could penetrate to. Wow. I think that's it. I think we got them all. I don't see any other questions coming in. Hopefully that answered them all. And I guess that wraps it up for tonight. And again, I want to thank everybody for your attendance tonight. I hope this is meaningful. And if please don't hesitate to send me an email or something if I didn't answer your question or didn't give you a good enough answer. I'll try to research it for you and get back to you. But thank you all very much, and I enjoyed being with you tonight. Thank you.